The caesarean section rate has increased internationally and in New Zealand. The rate in New Zealand increased from 19.4% in 1999 to 24.1% in 2007 and is currently at about 30% nationally. The rate in the Palmerston North Hospital specifically has increased from 24% to about 30% over the last 2 years. It is this increased rate in the caesarean section at Palmerston North Hospital that led to a multidisciplinary group of midwives, both employed and self-employed, and obstetricians to undertake an audit to determine the reasons for the unnecessary caesarean sections and to determine if there were ways in which they could address some of those issues. One of the areas that was identified for action was to support women to have a VBAC, vaginal birth after caesarean section. In New Zealand, midwives are required to recommend that women have a consultation with an obstetrician if they've had a previous caesarean section, to ensure that women receive consistent information about vaginal birth after caesarean section and to enable them to make an informed decision about their future birthing. The idea of this video and pilot project was born. Caesarean section is a major abdominal operation. This operation may be done for various reasons. In a study that was undertaken in Australia recently, women identified that caesarean sections for them were undertaken as a life-saving measure. For others, they didn't know of any specific clinical reason for the caesarean section, while others said that they chose to have a caesarean section. Whatever the reason the woman in the above study gave for having their caesarean section, they also indicated that they had experienced some unanticipated and unwanted side effects as a result of the caesarean section. Some of these negative physical health outcomes which affected their recovery included pain, reduced mobility, wound infection, and incontinence. Now, not all of these effects are specifically related to a caesarean section. It is important, however, to remember that unnecessary caesarean sections can create great risks for the mother and baby. And when a decision is made to perform a caesarean section, the benefits must be weighed up against the harms to both mother and baby.
With my first baby, I laboured spontaneously at 41 weeks, and laboured at home for a short time and then came into hospital. I had an epidural for pain relief, but I was progressing quite slowly and ended up having a syntocin and a drip popped in just to help my contractions speed up a bit or become more effective. Didn't really work too well, so I therefore had an emergency caesarean section at 9 centimetres for failure to progress, really. So 2 years later, I had my second baby. I was really keen for a vaginal birth, so I had some acupuncture at 36 weeks onwards. I laboured spontaneously at 40 weeks, on my due date actually, and laboured at home quite well. My waters broke about 4 centimetres or so, came into hospital shortly after and needed some pain relief, so I had an epidural. Laboured pretty well. Soon after epidural insertion I was fully dilated and was pushing, but needed some assistance, so I had a ventouse birth. With that second birth, as it was a vaginal birth after caesarean section, so a trial of labour, I had to be monitored quite closely, so with a CTG monitoring, just to check baby's heart rate, and I had to also have an IV cannula put in, so a drip. So for my third baby that I have just recently had, It was again a vaginal birth after a caesarean section, so a trial of labour. After having acupuncture from 36 weeks, I went into labour at 38 weeks and had a pretty quick labour and managed to push my baby out on my own with no assistance, which I was absolutely thrilled with.
I had a woman just recently who had a previous caesarean section because her baby was lying breech. And when she fell pregnant this time, she made contact and said, I absolutely do not want to have another caesarean section. I want a vaginal birth. So we talked about all the pros and cons and what would be required. She was determined, absolutely determined. Nothing was going to stop her. Her due date came and her due date went. And she still showed no signs of labour. And we talked about going overdue and what she wanted to do. And she said, well, I'm really happy to wait. So at 41 weeks plus 3 days, we went to the hospital to have a post-dates assessment done. And everything was fine. The placenta was fine. There was enough fluid around the baby. Baby's lungs had good breathing movements. It was moving well otherwise. And so she said, I still want to wait. And so we waited. We were then coming back on the Monday, which was 41 weeks plus 6 days, so just short of 42 weeks, to come have another post-dates assessment. And that night she went into labour, the night before that 41 weeks plus 6 days assessment. And she laboured beautifully. She did have a little bit of meconium liquor. We did all the things that are recommended, like a cannula in, constant monitoring, her labouring in hospital, and she birthed this beautiful over 4 kilo baby vaginally, and she was thrilled to bits. So again, it's sometimes the determination of a woman that will lead to the success.
I'm Dr. Jacqueline Hanson, an O&G consultant at Palmerston North Hospital. I was trained in obstetrics and gynecology in the U.S. at the University of Kentucky Medical Center. I would like to present the risk and benefits of a trial of labor after caesarean section or vaginal birth after caesarean. Following this will be a question and answer session. We hope this presentation will answer your questions concerning caesarean section, trial of labor, and vaginal birth after a caesarean section. For a woman with a prior caesarean section, there are 3 possible options. 1, a successful vaginal delivery. 2, a failed trial of labor and a repeat caesarean section. Or 3, a scheduled elective repeat caesarean section. In 1916, the statement, once a caesarean, always a caesarean, was made at a New York meeting of obstetricians, and for the next 60-plus years, this has been our management. But our studies and experiences have consistently shown that 60 to 80% of women can safely deliver vaginally after a previous caesarean section, and that a vaginal delivery is associated with fewer complications than a caesarean section. These include a decreased risk of hemorrhage or bleeding and blood transfusions, a decreased risk of infection, a decreased risk of blood clots, a shorter hospital stay and a more rapid recovery, fewer breathing problems for the baby, and fewer admissions of the babies to the intensive care unit. A failed trial of labor is associated with the highest risk, including hemorrhage, blood transfusions, infections, hysterectomy, operative injury, and rare death of the mother or baby. The most significant complication or risk associated with a trial of labor is uterine rupture. Uterine rupture is the tearing open or the rupturing of the scar on the uterus. The actual rate of uterine rupture is between 0.5% and 1.5%, or essentially 1 per 100 patients. The most serious complications of uterine rupture are hysterectomy, fetal injury, or maternal injury. The most common sign of uterine rupture is the fall in the baby's heartbeat or fetal distress. The type of scar or incision on the uterus is associated with the uterine rupture rate. A low transverse uterine incision, the most common type, is associated with the lowest risk of 1 per 100. The classical or T incision is associated with the highest incidence of uterine rupture, occurring in 6 to 12 per 100 patients. The type of skin incision does not always indicate the type of uterine incision, so it is important to review your operative records to determine the incision type. There are contraindications for a trial of labor. These include a previous classical or T incision of the uterus, a previous uterine rupture, conditions that should not be allowed to labor, such as breach or malpresentation of the baby, placenta previa, or previous uterine surgery, or a woman who adamantly declines a trial of labor and requests a repeat cesarean section. There are predictors of a successful trial of labor. These include if your previous cesarean section was for non-reoccurring reasons, such as breach, fetal distress, placenta previa, or high blood pressure. If you have had a previous vaginal delivery. If your labor is not induced, but natural labor. If you have a normal progress in labor. If your pregnancy does not go beyond 41 weeks. If your baby weighs less than 4 kilos. If the timing between your pregnancies is greater than 18 months. If you have a healthy, active lifestyle with a normal pre-pregnancy weight and a normal weight gain during your pregnancy. And if you are younger than 40 years of age. Conversely, there are factors that decrease your chance of success. These include, again, no previous vaginal deliveries, failure to progress in labor as the main reason for your previous cesarean section, induction of labor for greater than 41 weeks gestation, obesity, inactivity, and advanced maternal age. A special circumstance to be considered is induction of labor. Induction of labor remains an option, although is less successful than spontaneous labor. The use of prostaglandins for ripening of your cervix is not recommended because of the significant increase in uterine rupture rate and complications. But rupture of your membranes and the use of Syntocin to augment labor appears to be safe if monitored closely. Other special circumstances include 2 or more previous cesarean sections and/or a twin gestation. Limited studies are available, but there are still a 60 to 80% success rate without any significant increase in complications for the baby or mother. Recommendations for the management of labor include Labor and delivery in a hospital where an emergency cesarean section can be performed if necessary. The monitoring of the baby's heartbeat, since the most reliable and earliest sign of uterine rupture is a fall in the fetal heart rate or fetal distress. Intravenous or cannula access to administer fluids, drugs, or blood if an emergency occurs. Vaginal examinations to determine the normal progress of labor, since prolonged labor is associated with an increased risk of failure and uterine rupture. Epidural anesthesia is a safe option for pain relief during labor. In summary, a vaginal delivery after a previous cesarean section is successful 60 to 80% of the time. Uterine rupture is a rare complication occurring less than 1% of the time. All patients who have had a previous cesarean section should be given information on trial of labor and vaginal delivery. They should have a thorough discussion of their options with their midwife, who will refer them for consultation with the physician.
So I got to full dilatation last time and my baby was looking up at the stars. He was the wrong way around. What's the likelihood of that happening again?
Failure to progress in labor is the one classification or cause for cesarean section that actually lowers your chance of a vaginal delivery. But you said your baby was in the OP presentation or looking up at the stars. If this baby comes into the pelvis in the right orientation, then you would have a higher success rate of a vaginal delivery.
I've had 3 previous caesarean sections and I'm pregnant with my 4th baby and I really want a normal birth this time. The reasons for the caesarean sections were my first 2 I was induced, but I don't actually really know why. And the 3rd pregnancy I went into labour spontaneously, but my baby got into distress and so I had to have a caesarean section. So I'm just wondering what my options are.
We have no literature or no studies that look at 3 previous caesarean sections. It is not recommended, at least in the United States, that you undergo a trial of labor. With each subsequent caesarean section, the uterus does not heal as well and the scar is not as strong.
With my first birth, I had a caesarean because my baby was distressed in labour. I'd just like to know what my options would be for birthing this time, whether I would have to have another caesarean or whether I could try for a labour and a natural birth.
You are one of the candidates, one of the better candidates for a trial of labor, since fetal distress does not always occur with each pregnancy. I would simply recommend that you be monitored closer during the labor to make sure that this baby tolerates labor well.
With my first pregnancy, I was induced and ended up with an emergency caesarean section. And I'm just wondering, what happens if I go over my due date this time? And how far over am I allowed to go? And will I be able to have an induction, given that I've had a caesarean section before?
Optimally, we would like for you to go into spontaneous labor on your own. That increases your chance of a vaginal delivery. But if you do go post-dates, induction of labor is an option, although ripening of the cervix with prostaglandins, which we do, is not an option. Induction by artificially rupturing your membranes and allowing normal labor to progress is an option that's not associated with increased risk to you. Also, the use of Syntocin to augment your labor is not associated with any significant increase in risk. My recommendation would be that your midwife examine you starting at about 37 to 38 weeks. If your cervix is ripe enough, a stretch and sweep be done.
My last pregnancy, which was my first one, my baby was sitting breech, so bottom down, and I was really disappointed because they wouldn't let me have a labour and birth. I had to have a caesarean section. So this time I'm hoping to get pregnant soon, and I'm really hoping to have a normal birth. Can I have a labour and a birth after having an elective caesarean section without ever labouring?
Yes, you are the ideal candidate for a trial of labour after a previous caesarean section, as long as this baby also presents vertex or head first instead of breech.
I was just wondering, is there anything that I can do during my pregnancy that will maximise my chance of a labour and a vaginal birth?
Yes, there are a number of things that women can do to help them more successfully have a vaginal birth after caesarean section. Things that we certainly recommend are to watch your weight gain. And remember that weight gain is usually influenced by the fact that people put things in their mouths, which are not usually good for them. So you have to avoid a lot of carbohydrates, a lot of sugary foods, and particularly fruit juices can be problematic for increasing women's weight gain. We no longer say you must eat for two when you're pregnant. Small amounts are better more often than larger amounts. So the other important thing is to exercise every day. About a 20 to 30 minute walk every day is useful. We are not expecting any woman who's pregnant to start any vigorous exercise that they've never done before when they're pregnant. So rather something that you know is manageable will be beneficial. That will keep your weight gain down and will also help to maximize your chances of having a vaginal birth after a caesarean section. There are a number of other things that women can try, things like acupuncture. Some of the midwives can do acupuncture for their women, so it's something worth talking to your midwife about, but there are professionals whose business it is to actually do acupuncture, and you can make contact with them. Osteopathy is good, so that if you're having any back problems or problems with your pelvis, it may be worthwhile getting that sorted out before you actually go into labour. And there are some natural remedies that people use, but obviously the best people to consult about those things are the people who are experts or professionals with qualifications in those areas. And then of course there are a whole lot of recipes that people have for getting themselves into labour. There are things that the obstetricians recommend, like doing stretches and sweeps. Now, a stretch and sweep is basically where a vaginal examination is done and the cervix is stretched and the membranes are swept around to release prostaglandins, which will help you go into labour. Because the key is you don't want an induction if you've had a previous caesarean section. You want to go into labour spontaneously. The 3 H's stand for hot curry, hot bath, and hot sex. So it's well worth giving some of those things a try. One of the major things, however, is to have a mindset that says, I can do this. I can labour and birth successfully. So all the best with that and with your decision making about a vaginal birth after caesarean section.